Hey everyone, thanks for joining Baltimore County Fire Department EMS Academy. My name is Sean Barinholtz. I am an anesthesia and ICU doc at Hopkins. I am an active volunteer, Pikesville Volunteer Fire Company in Baltimore County, and I have the honor of serving as one of the associate medical directors for Baltimore County Fire Department. On behalf of the medical director's office, Dr. Andy Pollack, Dr. Jeff Sagal, one of the other associate medical directors I know is with us tonight as well. On behalf of the EMS office, Chief Shenning, Captain Stewart, Captain Fitzpatrick, thanks for being here, you guys. Thanks for what you guys do every day. Thanks for your dedication to lifelong learning. A big shout out tonight to Ashley Brooks. Ashley is a volunteer at Pikesville Volunteer Fire Company. Ashley is helping us run the Zoom platform. Ashley will be sending out a link in the chat. Click on the link, get your CEUs, your MIM CEUs. So if you want your MIM CEUs, keep an eye out on the chat. We'll announce it as well. Ashley will send out a link. Please remember that any challenges with signing in tonight for attendance, please chat with Ashley or I before the training is over. We're unable to accept emails around challenges with the link or getting to your CEUs during the training. Hope that makes sense. We're super excited tonight to have back with us again, Cindy Colson. Cindy has worked in the medical field for 20 years, gaining experience as a paramedic and then later as a pediatric ICU nurse. She's passionate about advancing the pediatric education for emergency medical services. In addition to providing education to EMS, she is also involved in injury prevention efforts and quality improvement in the care of the injured child at Children's National. If you haven't had a chance, Cindy also in December gave us a really spectacular training on pediatric burn injuries. That training is available on the Pikesville Volunteer Fire Company YouTube site, and we can send a link to those past trainings as well in the chat. So Cindy, thank you yet again for being with us tonight. I know that you have been working since 6 o'clock this morning, so yeah, we super appreciate you as always. Thanks.
And so have you. One thing that I can't see, and I just realized, Sean, on my end is the chat. So if somebody says anything in it, would you mind like stopping me?
You got it.
Okay, awesome. Well, thank you guys so much for having me tonight. And I am here to talk to you about being advocates for children. And that is one thing that we all have in common, no matter what we are doing on this call, is that it is our job to protect kids, and it is all of our jobs. We are all mandated reporters. So we're just going to briefly go over like what we can do to identify abuse, discuss reporting abuse, and then a little bit about preventing abuse. So every year, the Social Services and the U.S. Department of Health and Human Services, they put out a report. It's called the National Child Maltreatment Report. This is the most recent one. When I made this presentation, 2020 might be out. It always seems to be like a year or two behind. This is located, you can Google it and you can download the PDF if you want some light reading for a fun Friday night. This gives us like all of the statistics about child maltreatment as a whole for the United States. So at the beginning of this, I'm just going to share with you some of the national statistics, which is, it'll show you where the problems are and that it continues to be a problem. And just to give you some backstory of why I'm so passionate about this topic. So every year, 4.4 million total referrals are brought into CPS or Health and Human Services, including 7.9 million children. You know, that disconnect is often if between like the 4.4 and the 7.9 million, that disconnect is often if there's one child in the home. That report is made for like all of the siblings as well. And when we're talking about who's reporting child maltreatment, I realize that the words down here are like very small and not a great font, but the people that are reporting are education personnel, legal law enforcement, medical personnel. That's where we're falling under, non-professionals, and unclassified. So the non-professionals, those are people who are not in a job that requires them to interact with children. So that would be a neighbor or a babysitter or aunt, uncle, cousin. And I'm really not quite sure what unclassified means, but moving on. When we're talking about child abuse and who's at risk, And feel free to unmute yourself if you would like to answer. Do you guys think that there is a particular age that's more at risk than another?
Probably like 5, 7 and under.
Okay, that is a great point. So yes, it is younger children that are that have higher instances of like dying from their injuries. But when we look at it as a whole, it is like all children are vulnerable, and it's not like one set more than the other. When we talk about fatalities, it's a little bit different, but it's every age. So whenever you interact with a child, no matter what the age is, I always say, like, just keep it in the back of your mind, like, just always remember that every child is at risk. I'm going to just share with you some more statistics about who the victims were in 2019. So less than 1 year, and that is exactly what you were saying, has the highest rate of victimization. So the children under 1. Girls are victimized more than boys. American Indian or Alaskan Native children have the highest rate of victimization in the population, and African American children have the second highest rate. And then when we're talking about maltreatment, I feel like maltreatment is like quite a big bucket. So when we talk about maltreatment as a whole, that includes, neglect, physical abuse, sexual abuse, and then sometimes there's more than one thing going on. And when you look at this pie, I'm sure that it doesn't surprise you that like the largest piece is for neglect. And then it gets, then you can see the physical abuse, that's the orange piece. You see sexual abuse, that's the blue piece. And then you see the gray piece, and that is when there is like 2 or more maltreatment types going on. And then we're talking about children who are dying from their injuries. It is the youngest children that are the most vulnerable. So almost half are under a year old. Boys have a higher child fatality rate, and the rate of African-American child fatalities is 2.3 times higher than the rate of white children and 2.7 times higher than the rate of Hispanic children. But overall, over 1,800 children die every year from abuse and neglect in our country. And I think that those, that definitely proves to us that, this is not a good thing. This is still happening. This is still happening on a daily basis. And this is something that we always need to be mindful about when we are providing care to children, taking care of children, interacting with any children. And I think like the question that we would all ask when Sean, was there a question?
Yeah, that's really good that you picked up on the unmute. That's really good. Yeah, so somebody asked, I think it was about the age groups, but they were asking, why do you think that these groups have the highest rates?
I don't know. From when we're talking about from an age standpoint, I think that makes a lot of sense. Children under 1, they can't talk, they can't say no. They also can't communicate their needs effectively. Right. They can't say, Mom, my ear hurts, or I'm hungry. And also children at that age, they have this thing called the period of purple crying. And in medicine and in the literature, it's called colic, but it's a natural thing that happens with all children. And some kids just cry more than others, but all kids go through this wave of like, they cry for no reason, and then it gets a lot worse. It starts at like 2 weeks, peaks at 2 months, and then slowly tapers off. But you have a high crier where these kids can cry for up to like 6 hours a day and can't be soothed. That is a recipe for abusive head trauma, and that is where we see a lot of those things happening in this age range.
Yeah, I wonder, Cindy, if we want to just take a second and see if you can get access to the chat, because I remember in the past and now people are chiming in with some thoughts that I think you would really appreciate. So if you hover on the bottom, does the chat function come up?
Yeah, so because I'm using the extra screen for the presentation, it kind of blacks out a lot of things, but I was able to pull up the chat.
Oh, perfect. Great.
So there are some social and economical things, but I will tell you that child abuse does not know Like, it doesn't matter what race you are or what your economic status is, but what we are seeing with those statistics are there are some higher rates in certain areas. Okay, we'll just continue going on. So with looking at all of these things and knowing that this is a problem, I feel like the question for all of us is, who are the perpetrators? Who are they? And so again, all of this data is based and coming directly out of that National Child Maltreatment Report that is available online to the public. And so we know from this report that 83% of the perpetrators are between the ages of 18 and 44. More than half are female. And the three largest percentages of perpetrators are almost at 50% white, 21% African-American, and 19% Hispanic. And the one thing that I think is probably the most important thing to look at it on here is that over 75% of the perpetrators are a parent to their victim. And, that really makes me think about especially the pandemic, where everybody was saying, you're safer at home. And, you should be safest at home, no matter what. But for some children, they weren't safer at home. And, that's a very sober thought, but, that's why we're here. So, so how do we identify non-accidental trauma? How do we identify child abuse? And that is assessment, 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 assessment. So we're going to just briefly go through some red flags that should kind of like, I feel like everybody here knows what that spidey sense is when you get like that feeling of like, something's not right here. So when, if you have a frequent flyer, so 3 or more ER visits, 3 or more 911 calls, when everybody has those frequent flyers, but when it's when it's a kid or even an adult, I mean, because we can talk about, elder abuse as well, and, domestic cases as well, frequent flyers. When the history is inconsistent with when it's inconsistent with the story, or inconsistent with, if the history keeps on changing. So they give you, on scene, they give you one story, then in the back of the ambulance, you get another story. And then when you get to the ER, all of a sudden the story changed again. When the history is not consistent with the exam. So, if you get the history and then you look at the injuries and you're like, I don't even understand how that happened. When there's a delay in presentation, so older injuries, when you, and you don't need to be like an expert to know when something is old and when something is new. When you have any type of fracture or head injury in a children that's under 1, and bruising in non-mobile children. So that's one that we should really think about. So bruising is the earliest and most common form of physical child abuse. It's also the most easily recognized sign of child abuse, but unfortunately, it's also the most common direct sign of physical abuse to be missed. Because we all know that kids fall when they're walking, kids are running into everything, and we miss it. So there's, the rule out there, those who cruise rarely bruise. So if you take a peek at this graph here, you can see that bruises in infants and toddlers, you can see how it jumps up right at 9 to 11 months, right where kids are starting to cruise, right when they're pulling themselves up and starting to walk, and it gets higher and higher and higher as they, turn into toddlers. And so if you have a bruise in a child under a year, you really need to look at it and get that story, because that is, that's the one time where people just, people don't want to believe it, and will believe almost anything, even if it doesn't make sense. Some things that we've heard here, and that I've heard concerning histories when you have an infant with bruising, he laid on something, you don't get a bruise from laying on something. She must have fallen against the side of the crib. So if you think about, how hard you have to hit something, like in a bony prominence to get a bruise. The cat must have been in the crib. His brother probably did it. Oh, she just hits herself in the face and a toy fell on him. those are all like concerning history for infants with bruising. So if you hear these things, it's just a note to you to kind of step back and really look at the situation. There's something called the 10-4 bruising model. So this is quite sensitive and quite specific for detecting child abuse in children. So I love it because it's an acronym and I think it's easy to remember. So we have 10 and 4. So 10, TEN, stands for torso, ears, and neck. So if you have bruising in the torso, ears, or neck area in children under 4, or more than 4 bruises in the very young, and any bruising at all in a child under 4 months of age, that is indicative of abuse. And that sensitivity is 96 and the specificity is 87%. So the torso in children, I mean, there's a lot of cushion, and cushion absorbs injury forces and bruises rarely. Direct abdominal blows can cause internal injury with minimal external bruising. So what you see isn't always what you get. Oh, I saw in the chat, they forget to tie their shoes a lot when the shoes are tied and they trip. Yes. Again, that's another great statement of like something that you want to be like pay attention to. So the torso, again, there's like a lot of cushion to absorb those forces. So if you see minimal bruising on a torso, just remember that of like what lives under the torso. And you can bleed a lot on the inside with having a very small bruise on the outside. Bruising to the ears are very difficult to bruise. They aren't very vascular, so they do not bruise easily. And bruising to the neck. So if you think about kids and even trying to put a C-collar on them, or trying, I mean, God forbid you're going to have to like intubate an infant in the field, but they have no necks. Like it's like this big one, like a watermelon sitting on shoulders. Those shoulders are protecting their neck. The shoulders protect the necks of children even from short falls. So if you have bruising to that area, that is concerning. So TEN, so torso, ears, and neck, and then the number 4. So bruising to those areas in children under 4, or more than 4 bruises in the very young, or any bruising on an infant less than 4 months of age. So this was in an article in 2021, and it's been used a lot longer than 2021, but this was in a recent article. And then there is an additional part to the 10-4, and that's called the 10-4 phases. So the phases part adds another acronym to it, to other areas that if you are seeing injury or bruising, you have like a high index suspicion of child abuse. Okay, so, and here are the areas. So faces, other area you have like a. So the other, so faces is also another acronym. So we have frenulum tears, auricular area. So that's again the ear, cheek, eyelid, and sclera. So the frenulum is that little piece of skin that it kind of connects like and if you look down here, so you can see like that's a little piece of skin that kind of connects the lip to the gum line here. And then there's also another frenulum is right underneath the tongue. Now, when you see a frenulum tear, that is that's highly indicative of something is going awry. And a lot of people ask, well, how do kids get frenulum tears? So one of the ways you can get a frenulum tear as a baby is with forced feeding. So if you think about, the baby that won't stop crying, and the caregiver can get like extremely frustrated and they're trying to like feed the baby. And if they keep that nipple in the mouth and keep forcing it, that can tear the frenulum on either underneath the tongue or at the lip. Another, blunt force trauma is like another way. So now that I've gone through some things to think about and some areas to just remember, and I feel like that's probably the most important thing for the entire night is just remembering the 10-4 faces. I think that's like a really good guide, and it's something that I wish that I would have learned a long time ago. When I read this, I was like, this makes so much sense. This is very helpful. But I have a few case studies that we can go through unless there is any questions at the moment. All right. All right. So we have a 5-month-old female, Bethany. Mom called 911 for 4 days of not moving her right arm and localized swelling. And I feel like, everybody's probably like, well, why'd you call 911 for 4 days of not moving her right arm and localized swelling? But, we've all been there. So there we go. So she called 911 because Bethany was not moving her left arm and there was some bruising noted. The past medical history is that she went to the ER the week before for a bleeding lesion under her tongue. They drew some labs because they were concerned about a bleeding issue, like hemophilia or some other thing. And they sent her home because they were normal. And when she got to the ER, she was diagnosed with a bucket handle fracture of her distal humerus. So here is a picture of the x-ray. I am not a radiologist, but I would call this the positive arrow sign. Whenever you have an arrow on an x-ray, it kind of is showing you exactly where the problem is. So here's the humerus, and you can see like the little shadow right here, and that is what they call a bucket handle fracture. So when mom was told that Bethany had a fracture, she stated, well, the ER held her down roughly to get blood when they were there 4 days ago. Then she also stated she bumped my arm. The baby bumped her arm in the ambulance because they weren't careful with my baby. So interesting enough, like all of the swelling occurred like 4 days after the blood draw. And the diagnosis was the bucket handle fracture of the distal humerus. And so Bethany was admitted to the hospital and needed to go to the OR and had a non-accidental trauma evaluation because of this fracture and because of the concerns with her story. So a little bit about bucket handle fracture. It's a specific characteristic of inflicted injury. Now, obviously, you guys are not going to have x-rays in the field. I just think I think this is an interesting story. It's related to the shearing forces generated by rapid acceleration, deceleration, or torsion. So if somebody is like yanking a kid by their arm or twisting the arm. When orthopedics took a peek at her, at the arm, they were concerned with a more extensive fracture that needed reduction in the OR. So she went to the OR, then the PACU, then the floor, and then had a CAPC consult. So CAPC is the Child and Adolescent Protection Center. Oh, wait, there's a question. Are they a daycare or is there a provider that watches the kids at home? They were not in daycare and they were just at home with mom the entire time. And I told you
this injury like a more severe form of like a nursemaid's elbow, or is it like a more extreme? You know what I mean?
Yeah, it's extreme. So for the nursemaid's elbow, normally that's just a light tug that happens. But to have like a fracture and a bucket handle fracture of the distal humerus, you really have to have that rapid acceleration, deceleration, or that torsion to like twist and
Torsion,
pull.
got it. Thanks.
Yeah. And then so CAPC in our hospital, those are our child abuse doctors. So it's child and adolescent protection. And just to give you guys some information of like what happens if child abuse is suspected or if there is a concern for child abuse at the hospital. This is just like what we do for the workup. So all kids with concern under 2, they get a skeletal survey. So that is an x-ray of every single bone of their body. Any child under 1 or of any child with any altered mental status, they'll get a head CT and a D-dimer. We will do an abdominal CT if they have elevated transaminase levels or if there's evidence of abdominal trauma. Remember when we were talking about how if there is a small bruise on an abdomen, there could be something way worse going on inside. We do a CBC, BMP, amylase, lipase. We do liver enzymes. We do a urinalysis, we do a urine tox screen. Now, we also at the same time do OI labs. Anybody want to talk to me about OI and why we would do that?
To see if there's
So
some sort
OI
of bleeding disorder like hemophilia or something.
Yes, 100%. And then OI is osteogenesis imperfecta. So that is some people call it brittle bone disease. And so we do all of those labs to rule out any medical reason of why this could be happening. And then when we talk about the blood disorder labs, as you were saying, for like hemophilia or like random things that would cause you to have like random blood disorders, we always want to make sure that if the child does need blood, that all of those labs, we always make sure that we get them before they're given any blood, because once they're given blood, we are, it's not going to work anymore. So the final disposition for Bethany's story, her skeletal survey was negative. Her head CT was negative. There was confirmed abuse. Mom eventually did say that she was the perpetrator and that she did it. And at that point, Bethany was placed into foster care because there was a whole lot of other things going on at that time. So let's go through some of the red flags for Bethany. So there was swelling and bruising that were supposedly occurred 4 days after the IV placement that was so rough. So that doesn't make sense. Questionable injury after this extremely rough ambulance ride. This is a non-mobile child with a fracture. So this is a 5-month-old. Non-mobile children with fractures, it's definitely concerning. She had an ER visit for a bleeding mouth that could have been a frenulum injury. I put non-mobile child with fracture on there twice. Apparently, I thought that was very important. And then when a chart review was done of all of her previous visits at her primary care and any other ER visits, it was found that she went to her primary care visit like a month before with a bleeding mouth. So all of those things were showing up that indeed something was definitely going on with Bethany. It was not legit. Okay, so moving on, we will talk about a 21-month-old boy named David. So you get a call for a toddler that fell into a bathtub. Okay, so the background, he had no medical history. 911 was called because David fell into the bathtub. Mom was not at home during this time. It was the boyfriend that called 911 because mom was at a mandatory meeting for housing. And David was left in care of mom's boyfriend with 2 additional siblings at home. So when EMS gets on the scene, this is what they see. They see 40% total body surface area, partial thickness burns with clear demarcations, no splash patterns to the chest, back, arms, left leg, entire GU area, and buttocks. There was linear ecchymosis to the anterior neck that were ligature injuries. There was ecchymosis to the left cheek, the left ear, and the left eyelid, and the upper frenulum was torn.
Can you clarify so the burn, so no splash pattern, period, chest, back, arms, left leg. So those are where the burns were?
Yes.
Chest, back, arms, left leg, entire GU, and buttocks.
And he
So
was
it's
dipping them. He was dipping them.
Correct. So yeah, no splash patterns whatsoever. And then, okay. And then when the patient was brought to the ER, they also noted the 40% partial thickness burns without the splash pattern, also noted the linear ecchymosis to the anterior neck, the ecchymosis to the left ear, left cheek, left ear, left eyelid with the upper frenulum torn. And then we also did a head CT and there was a subdural bleed. So again, I am not a radiologist, but this has a positive arrow sign. And this is a little bit bigger. So you can see right here, you can see the bleed. And then right here, you can see the bleed. So the questions that we would ask ourselves, like when you get onto the scene for EMS, because you were called that he fell into a bathtub. So does your assessment match the report you got? Now this one's very easy. It's like, no, this does not match. But the question is like, and things to think about are like, do you see any additional bruising? So really looking at the kiddo from head to toe, like you see all of that, like all of the burns, and that can be very distracting to take care of a 21-month-old with all of that, with like 40% burns. But we can't forget to say, okay, none of this matches, and to really do a good assessment. I mean, we want to do a good assessment on all of our kids, and looking to see if you you see anything else that's going on. You know, a lot of the times if you have a toddler with a 40% burn, I don't think that you're probably thinking about looking in the mouth to see if there is a frenulum injury. But these are things to think about, and this is all of these pieces are part of your assessment, and that will help providers once they get to, you know, their final like area of treatment. And one thing to note is just because someone before you didn't have concern for non-accidental trauma, it doesn't mean that you're wrong. Don't let people talk you out of your instincts. So if you are concerned about something, or if you want to do a more focused assessment, don't let people talk you out of it. If you're concerned, you know, make your report. You know, call CPS if you're concerned. It's never going to hurt anybody. It just means that you have done everything that you can do and everything that, you know, is mandated for you to do. So the final disposition and all of the injuries that David had after they did, you know, the skeletal survey and all of the other things. So he had, as you said, an emergent scald burn. He had subdural hematomas. He also had a grade 4 liver lac. He had a torn frenulum. He had a healing 8th rib fracture, an acute 9th rib fracture, a subacute left femur fracture. So this child showed signs of chronic and acute abuse. David ended up doing very well and was discharged to inpatient rehab to, you know, for his burns and to recover from his head injury and all of the things. And mom's boyfriend was taken into police custody. Red flags for this case. I think we Carol Ann, you picked up on this right away, the clear demarcations and no splash pattern. The upper frenulum was torn. If you think about this kid, he's 21 months old, so he's probably not drinking out of a bottle. So this probably isn't a forced feeding thing. This is probably something else going on, possibly blunt trauma. We don't know. The story of falling into the bathtub is completely inconsistent with all of these injuries. And again, linear ecchymosis to the anterior neck. So, you know, any type of bruising to the neck, to the cheek. I mean, and you think about like the 10-4 faces. So you have the torso, the ear, and the neck. So he had bruising to his ear and his neck. And then if you think of faces, the frenulum was there, auricular, so the ear, the cheek, he had bruising on his cheek. I mean, he almost like hit all of them, and you don't need to hit all of them to have a concern. You only have to hit one. That we did have a question about any treatment for the mother of case 1. So when and the question was, mom charged these injuries did not occur on one occasion. So one of the things that is not in the documentation here is exactly what happens with the perpetrators. So our child and adolescent protection physicians, they are the ones that go to court in these cases and do testify. So sometimes we find out, and then sometimes stuff like this is on the news. And I did have a question about like any treatment for the mother. So I thought that was a really interesting question, because we are like, I feel like at first, like all we are concerned about is like treating the kids, but Obviously, if somebody is doing something to a child that is like this, like they need treatment as well. So whenever we have any child that comes in with concern of non-accidental trauma, we do have social work meet with them, but they don't follow up with them most of the time. That is CPS, Health and Human Services, and also the police sometimes. I hope that answered the questions, and I apologize. I don't mean to be vague, but and the question about the previous mom, yes, the mom was charged. All right, this is our last case. This is a 10-year-old Sarah. Sarah's mom called 911 for vomiting and right-sided abdominal pain. So say you are you are the crew that arrives to a house for a, hold on, how old did we say she was? She is 10. Oh, she's 10 years old, and she has been vomiting for 3 days, and she has right-sided abdominal pain. So what's on your differential diagnosis? This is not, I'm not trying to be tricky. I'm like just thinking about like what would you think with a 10-year-old with right-sided abdominal pain and vomiting for 3 days? What do you think?
Appendicitis.
Right, exactly. Appendicitis, maybe a kidney stone. Okay, so appendicitis, gastro, maybe an ovarian cyst or torsion. Pregnancy, can't ever rule out pregnancy, not even at 10, and constipation. All of these things can cause right-sided abdominal pain and vomiting. A little bit more about Sarah. So Sarah has had microcephaly at birth, and as a result of a chlamydia exposure, so mom had chlamydia and Sarah had microcephaly at birth, cerebellar hypoplasia, bilateral neurosensory hearing loss, and ataxia. So she had a history of falling a lot. She had a history of falling a lot because of her cerebellar hypoplasia and her microcephaly. And so she had a history of ataxia because of her condition. She was a known patient to EMS. She was a known patient to the hospital. She was hospitalized for multiple intracranial hemorrhages in the past from previous falls. And her most recent fall, she had an intracranial hemorrhage and a skull fracture, and that was a month ago. So that's just Sarah's history. So Sarah in the past had been worked up by neurology and multiple services. Mom was getting really frustrated about why they couldn't prevent Sarah from falling all the time. And you know how when you get on scene, you get like a whole bunch of the other history, not just what's going on. So, mom's saying, I can't keep her from falling all the time. And the most recent plan was to get a more detailed workup by neuro to ensure that, Sarah wasn't having seizures and then falling. A little bit more about Sarah. So Sarah's 10 years old, but she functions at a second grade level. She was enrolled in a charter school in DC, was seeing occupational therapy and physical therapy 3 times a week as part of her IEP. And again, we called 911 with complaint of vomiting, right-sided abdominal pain, and no history of trauma. So I'm going like pretty deep into this because I just wanted to be known that Sarah had been seen and was being seen by multiple providers on a consistent basis, like over and over and over. For her evaluation, got a lipase and an amylase. So so lipase was 4709. So these are pancreatic enzymes. A normal lipase is 10 to 140. So you can see that that's quite elevated. And her amylase was 803. And a normal amylase is 40 to like 140. We went ahead and did a head CT, and it was shown to be without intracranial hemorrhage. It was just ordered based on the patient's history, and she was just here a month ago. So, the question is, sometimes you can be vomiting because you have a head injury. So because she had a recent one, it's a good thing to do. So we went ahead and did that. And then a complete ultrasound of the appendix because she's a 10-year-old with vomiting and right-sided abdominal pain. The complete ultrasound of the appendix showed a abnormal enlargement and decreased echogenicity of the pancreas compatible with pancreatitis. So she was diagnosed with pancreatitis with an unknown etiology. So she was admitted to the hospital with a surgical consult for pancreatitis. And after she was admitted, she disclosed that she fell. No one saw her fall in the past day, and that she fell from a kitchen chair. There was no bruising noted to her abdomen, but she continued to complain of abdominal pain and continued to vomit throughout the night. Because she was continuing to have abdominal pain and continuing to vomit, when surgery saw her, they said, you know what, let's just go ahead and get an abdominal CT. Like, we did the ultrasound, everything looks like pancreatitis, but let's just do an abdominal CT to see what else might be going on. So when they did the abdominal CT, lo and behold, she had a transected pancreas, she had acute and healing rib fractures, and she had a possible pelvic fracture. And that was a surprise to everyone. So of course we called CAPC and started the NAT workup. So again, with the positive arrow sign, so right here, so I'll orient you to this. So this is the abdomen. This is the spine, kidney, and this right here kind of looks like a sausage. That's the pancreas. And see that break right in the middle? That's a transection. So when we talk about transected pancreas, the question is, like, how do you actually transect a pancreas? How does that happen? So the pancreas is a relatively, really well protected organ. It sits pretty high in the peritoneum, and it sits right up against the spine. It's less than 2% of blunt trauma injuries result in a transected pancreas. It is very rare. And it comes from a sudden localized force to the upper abdomen that actually compresses the pancreas against the spine. And that's how you transect it. Ways that we see adults get a transected pancreas is if they aren't wearing their seatbelt and they get in a car accident and the steering wheel goes right into their chest and their upper abdomen. Sometimes we do see it in kids. It's a classic handlebar injury. So kids riding their bike, they go over the handlebars, and sometimes the handlebars will get them right in the gut. So it's like an extreme force pushing that pancreas up against the spine. So the moral of the story is you don't fall off of a chair in the kitchen and transect your pancreas. So when the child abuse doctors went through the chart review, I'll just give you a quick overview of it. So a week before, she was seen by nutrition, but she was failure to thrive. So she was not gaining weight on her regular diet. She was seen a month ago in the ER, which we talked about, for a fall. At that same time, she also had an ophthalmology consult. That was just a normal routine thing for her. 2 months prior, she was seen in the ER for a fall from the bunk bed. 9 months prior, she was had her neurology follow up. A year prior, she fell from that same bunk bed. You would think they would get rid of these bunk beds at this point, right? Especially with a child that had ataxia. I don't know why we were on a bunk bed, but there we go. 4 years prior, the primary care had a foot injury with the method was unclear. And 5 years prior, came to the ED for a hand burn with a delayed presentation. There are 4 previous CPS reports filed in the past and investigated, but with no current CPS involvement. And two of those CPS reports initiated a medical evaluation in the ED. So sometimes if somebody files a report that says, I'm concerned about this child, CPS will require that the provider bring them into the emergency department for a medical evaluation. So in the end, with Sarah, she was found to have isolated left ear bruising. This was not picked up until with our child abuse pediatricians, because as providers, EMS, nurses, physicians, surgery, when you have a 10-year-old with abdominal pain, you're not looking at their ears very much. So this was picked up late. That abdominal CT, we showed healing and acute rib fractures. Obviously that transected pancreas, signs of acute and chronic abuse. And Sarah ended up doing very well. She was discharged to inpatient rehabs and the parents were only allowed to have supervised visits. Now, Sarah's tricky. So, you know, her red flags, she had multiple visits and her injuries didn't match the story, but they weren't outright injuries. Sarah was tricky for everyone because you have a 10-year-old that's functioning at second grade level. So her communication skills are not the same as any 10-year-old. She had a medical history that it could explain many of these falls. And that's where that assessment comes in, because, you know, it's always, you never want to miss anything. I mean, you just never want to miss anything, because part of what we do is, and what I think is the most important thing, is we are advocates for these patients. And when you have patients that are even more vulnerable, like Sarah, because she's special needs, their rates of abuse are higher because they're higher because, I mean, there's lots of reasons why they could be higher, but I suspect that, you know, they aren't able to communicate the same way, and they probably are more difficult to care for, and that, you know, that can lead to all sorts of things. So a little bit about reporting abuse. So, hold please. In 2019, professionals, so that's us, submitted almost 70% of the reports for alleged child abuse and neglect. And we already had talked about like the difference between like professional and non-professional. And again, like we are all mandated reporters. So just don't forget that. And that is, I will say, that is me. Back in the day when I started at the fire department, I had to just like throw that in there. But we are all, you know, part of this whole network that is responsible for taking care of kids. And just remember, if you see something, just say something. And a couple things about like, you know, why do we miss abuse? You know, anybody have any thoughts about, you know, or want to discuss like why people, you know, sometimes miss abuse? So I think that a lot of times we just don't want to believe it. We want to say, this doesn't look right, but you know, I know this family, or you don't want to believe it. And then, you know, there's a question of like, am I inexperienced with kids? Is this a normal thing? You know, is there, wishful thinking, exactly. Denial. You're afraid to bring it up, you know, concerned that if your report, you know, makes that whole family get evaluated. What if that brings like distress to them? My question is, what if you're right? What if you're right? You know, if you're wrong and they do an investigation, okay. And yeah, no, a really a good question is knowing that CPS won't fix the problem. We got to give it a try. We have to try. There has been instances where I think that we have all, if you've been in this field for you know, more than a minute, you see so many things that happen and you're like, well, why didn't they do anything? Or why wasn't this caught? Or why wasn't this, you know, why didn't this happen? Or why are they still with the parents? Don't stop reporting. Don't stop caring. Don't stop advocating. You know, being afraid of a false allegation. So these CPS things, you do not have to give a name. So if you say that something, if you're concerned about something, you can do this anonymously. Yeah, calls do move quick. And sometimes you can't catch up on the subtle things. And I think that that's why having acronyms like the 10-4 faces can be really helpful, because that's something that's quick, it's down and dirty, it's fast, and you can be like, okay, I don't see that. This, you know, so I think that that's why it helps. Yeah, right. No, that is a good question. So somebody asked, like, why are there abused kids returned to the parents and caregivers who abuse them? And I do not think that our system takes kids away and then gives them back to the parents without the parents getting help and creating safety plans. And right, abusers can lie and talk sweet talk the system. That is definitely a thing. But one thing that we do know with and the literature has taught this to us is that kids always do better with their parents. Even if their parents had done something terrible before, if they get treatment and create a safety plan and have the right things in place, they do better. But people are always going to be people. And the purpose of this is we got to do what we can to keep kids as safe as we can. So there can be underreporting, there can be overreporting. You know, some kids are suspected less than others, some kids are reported more than others. You know, the question that you have to ask yourself is not, am I overreporting? Am I underreporting? What's going to happen? The question that we should all ask ourselves every single time is, are you concerned? Are you concerned? Were there red flags? You know, were there red flags? And every single time, apply the rules, no matter who the patient is. So, and that's, you know, that's the best of like the best way to do it with, you know, asking yourself, are you concerned? They hit any of these red flags? Does it fit into this model? And then apply those rules, no matter who the patient is. And if you see something, definitely say something. And then a couple things, because I feel like this talk is it's kind of heavy, and I don't want to end it with this. I want to end it with a little bit of like stuff that we are doing at Children's to prevent child abuse. You know, it's not gonna change the world, but we are doing our absolute best. And one of the programs that we teach is the period of purple crying. So I had talked a little bit about that before, but this is teaching parents and caregivers about the period of purple crying. And what's really neat is that because of our program in our hospital, now every single daycare provider in the District of Columbia has to take this training. So once a month I teach this, and so anybody who is in a like a child development center or a child development home has to learn about the period of purple crying, which is teaching about like early infant crying, and in the hopes to decrease the amount of abusive head trauma. And whenever we are teaching all of the daycare and school providers, one of the things that we do is ask them to share with the parents, because, you know, they have a bird's eye view into families' lives that we will never see. And then on the previous slide, I also had the no hit zone. So no hit zones are: no child shall hit an adult, no adult shall hit a child, no child shall hit another child, and no adult shall hit another adult. And so we have been working at Children's to become a no hit zone. We are not one yet, but the no hit zones have done like quite a bit of research on corporal punishment and confirmed a strong relationship between corporal punishment and physical abuse. And I had read like what a no hit zone policy is. And, you know, we at Children's thought it would be like we're a healing place, and we don't want any hitting of any sort like in our hospital either. So that is something that we are working on. And when you're looking at no hit zones, they are going like all over the United States. So if you see it, now you know what it means. And my last parting thought for you guys is that like just remember to that you are the voice of those who don't have one, and use it, and don't be afraid to, and thank you so much for what you do. I feel like right now we're hearing that all the time. Everybody in healthcare is like, thank you for what you do. But I haven't run on the ambulance since 2012, and I miss it every day. And I think that EMS is where it's at, and thank you for continuing to do it. I do have a few resources. I can like put these up like in the chat, and I have references and all of the things, but I think there's a couple other questions. So that is that's it. Thank you so
Indeed, that is
much.
spectacular. Thank you so much. So practical. You can tell you're passionate about it. You're such a dedicated, such a great educator. Thank you.
Oh, well, thank you. There is a question about safe discharge. I have time if you have time.
Hi, I'm Lieutenant Wenzel. So I work in the eye care program and I deal a lot with adult protective services. One thing that they tell us is that, yeah, that's great, we can report it, but it's the hospital's responsibility to come up with a safe discharge plan. And they won't even accept the case until after the patient has returned home to the hospital or returned home from the hospital. So in a case like your 10-year-old, where there's been 4 to 6 CPS cases, what is the hospital's responsibility for that safe discharge?
So the hospital, so every single child that there is ever a concern, social work gets involved, our child in a protection center gets involved. And I have to say, my background is being a PICU bedside nurse, and I have not worked in that section of the hospital. So I do know that our social workers and our child abuse team work with the family to create safe discharge plans when it is appropriate for the child to be discharged. But most often when we have kids that are inpatient, CPS comes to the hospital and everybody sits together and talks about it together. It's more of a joint decision making at that point. Now, if kids are going home from the ER, that's when a lot of people, I feel like that would probably be a little bit more sticky, but I do not have a great answer other than I know that social work is always involved and helps make that plan, not just with the family, but with CPS as well.
That's helpful. Thank you.
Oh, okay. Okay. Sorry.
Thanks for joining, Lieutenant Wenzel. Thank you.
I think there is a question about suspicious parent behavior.
Beth, do you want to unmute?
Can you put your site again if we have questions, Ms. Colson?
Oh, sure. I'll put in my, I'll give you guys my email.
And
Thank
we
you.
also put in the chat the link for CEUs,
Okay.
Colson Kids. Cindy put in the chat her email.
I got to make sure I put in my email, ccolson@childrensnational.org. Okay. I was like, did I put that in correctly?